in just as contrast with experimental data. This is by opposition how it's defined. It's not a particular definition. So, and why? Just because the experimental data, not just the experimental, actually, in the science paradigm, we are collecting data in many ways. We are collecting intendedly data in many ways for experimentation, but also to get populations involved in prospective cohorts, or conducting surveys that are predefined. This is the point, having a predefinition of what we want to collect and collect it. When we don't plan to collect data and just take advantage of the data routinely collected for other reasons, for other purposes, we talk about real-world data. So this is basically the way we present, contextualize the reuse of this real-world data, routine data collected for other purposes that we will be using for, to do research. So as you can imagine, this in the end implies that we are not doing randomized clinical trials. We are doing observational studies of any kind. Another point that I would like to raise: many times, real-world data and big data are considered synonymous, and they are not. Real-world data might be small data as well. And the differences with big data might be taken from this slide. Basically, to consider big data as part of the big data constellation should accomplish some of these elements. Let me, though, put the accent on 3 of them. The volume, which is a big one. A big one is, levels of magnitude is not even 200 million, rows in a huge data set. Is orders of magnitude what we are talking about. The velocity, so the velocity at which, the speed at which those data are refreshing, are updating, which implies in the end technological challenges to do with, and the variety. Heterogeneous data sources, heterogeneous data within those data sources, heterogeneous data in unstructured data sources. So this is the kind of element that actually exemplifies what a big data means. Velocity, volume, variety. So real-world data might be big data, yes, if this volume, velocity, variety, veracity, variability, and value applies. Otherwise, real-world data may be small data as well. And most of the things that we do in our real contexts, when we do research with the data, I'm positive most of you have actually been exposed to that. Most of the things that we do, I say, are done with small data, real world small data. So don't be mixed up about that. Real world data, routine data collected for any other purposes in real life contexts. Big data, high velocity, huge volume, extraordinary variety. Well, why these elements are so paramount today? Basically, there has been, we are all witnesses a change in the paradigm of science from experimental science to this other science produced by real data. So, and why? Well, the momentum is taken is just because we do have a lot of information collected already, rather structured. Every single contact with the health system actually, leaves a signal, leaves a track of someone that has been passing throughout. But at the same time, technologies, computing technologies and computing capacities have increased enormously in the past decade. So we do have the data and we do have the capacities to move the data. So this is the underlying reason. These are the underlying reasons because this is moving so fast. But at the same time, the paradigm, as I said, the science paradigm is also changing. Why is changing? The science paradigm is basically, if we look at, classical perspective or retrospective cohort studies or randomized clinical trials or clinical trials, experimental science or observational science of such a kind, the evidence that we get out of that is partial. It's always partial. It's very local. Usually it's quite local. Affects a number of patients that are not actual real patients or not the patients that we are used to treat in our real life. Normally, that evidence comes from different contexts. Contexts that might be similar to our, or maybe not. And we have to translate those findings into our contexts. And we do know that once we have a vaccine tested in one place, the efficacy of that vaccine can change dramatically in other different contexts. Same happens with any intervention, with any treatment, with any diagnostic test that we survey using experimental science. And there are a couple of things that also affect the classical paradigm of science in medicine. On the one hand, once you produce a result from a randomized clinical trials, updating that trial is so expensive that the findings are considered, over. And on the other hand, conducting big studies with many patients in many contexts takes time, and usually results come very after the need of someone making a decision, particularly decision makers. In contrast to this, what real-world data offers is the possibility of having in the same study real-life patients in real-life context with multiple complex interventions interacting, which is real life, on evolving data that refresh, at a higher pace, producing more up-to-date information for decision makers to make decisions in time. Well, nothing is true, nothing is false. Now, we are not just substituting in any way. I'm not advocating a change of complete change of paradigm. Randomized clinical trials are still current and are useful and are of value for many things. We do know now with the COVID vaccines, for example, we do need to know about safety. We do need to know about efficacy in control contexts. But it's true that we do need all the kind of research using real world data. So both things should actually share the science paradigm and enrich each other. This will be the point. But let's focus on real world data uses, and let's move quickly to the kind of data sources that we do have available at this point in time to do research with real world data. Basically, when we are talking about data sources that collect, produce, maintain, curate real world data, we're talking about these. Of course, lab data, mortality data and registries, social media data, pharmacy data, hospital data, claims data, survey data, electronic medical records, consumer data, wearables data, disease registries, any of those, if are collecting data in a routine way for any other purpose, are actually candidates for reuse. And those of that are examples of data sources that collect real world data. Just for you to have a hint of a number of those data sources, not all of those data sources, but those are all of us more familiar with. Those are, for example, generating the general data for patients in our healthcare systems in Spain, or the users database, or the electronic prescriptions, or dispensations, or vaccines, or hospital discharges, or primary care contacts, and so on and so forth. Just for you to have a hand of that, I say, 1 million lives produced in 1 year, 400 million data on, summary data on the conditions of the patient is suffering, 160 million reimbursement claims with a number of variables, attributes within those, 150 million dispensations, 20 million prescriptions, 100 million appointments in primary care, 40 million diagnostic tests, 45 million self-patient visits, etc., etc., etc. It's just for you to have a hint. I'm not including here, information on radiology. I'm not including here information on wearables. So that imagine the volume and the challenges in terms of technological aspects and on methodology. This is my last slide, but please don't get fascinated with the capacity we're getting on the reuse of real world data. Don't get the facts, the technology is there, the data are there, and we can get fascinated, but there are many methodological challenges that we are now struggling with when reusing real world data. This is kind one for you. If you are to use it, please take into account a number of methodological challenges that we have to consider when producing evidence out of real world data. Because real world data tend to be incomplete many times. You have to take this into account. How to treat missingness is one big point. Many times, because of the purposes of the collection is different, well, might be inaccurate data for research purposes. So let's take this into account and see whether we could use it or not to respond to a research question. Then massive data in terms of mathematics has implications. We cannot use the same mathematics when using that kind of volumes of data because of dimensionality, for example. And then if we want to go for, and very attractive pragmatic trials or prospective cohort studies looking for some causal inference. So to produce not just information about utilization, appropriateness, costs, differences in costs, and so on, but we want to go for causal inference. This policy, this intervention, this treatment has produced in real life this impact on patients or populations, then we have to be very careful with confounding. By design, randomized clinical trials try to avoid confounding. We don't have by design this opportunity. We have to create conditions to mimic a randomized clinical trial using this kind of research on real world data. So I'm closing here my overarching overview, and I'm giving the floor to our two presenters today. First of all, Marta Villegas, very much involved